Good afternoon, dear colleagues. Please take your seats. Okay, I hope you enjoy your lunch, and I would like to open the afternoon session of the lectures. And first of all, I would like to give you a few informations. We will have 3 lectures from our presenters. Then we have a short coffee break, and afterwards we will have workshops again. Okay, the same groups as you were in the morning. And I would like to introduce Associated Professor Thurnher from Austria, and with her lecture, CNS infections.
So hello everybody. Obviously lunch was good. Everybody is in a good mood. Maybe we will change this in workshops. Maybe we'll ask some nasty questions or be polite. Okay, so my topic will be CNS infections. I will not be able to cover all infections possible because the number is huge. So whatever I don't cover in the lecture, I plan to do with you in the workshop. So some diseases will be repeated, and some new maybe infections that I don't have time to show here, I will show later. So increasing number of immune compromised patients resulting from AIDS, from drug abuse, from organ and bone marrow transplants, even growing aging population has provided a unique opportunity for different organisms to cause infection. What are we going to do today? We will go with these parts. We will first start to discuss with you meningitis, then brain abscess, some encephalitis forms, herpes encephalitis and some others. And at the end, I will try to discuss with you some kind of a simplified approach to infections and kind of a diagnostic algorithm. So let's start with meningitis. The meningitis is some kind of a difficult diagnosis when you have a patient. Sometimes people go like, should I do CT or should I do MR? Should I even go immediately to lumbar puncture and then afterward do some imaging? Where I work in Vienna, we usually do CT before every lumbar puncture, although there is no really, how to say that, it's not really clear from the literature that we have to do it before every lumbar puncture, but they like to do it to exclude some other pathology. So these are the list of imaging findings that you might find in meningitis. You're looking for meningeal or dural enhancement. You're looking for hydrocephalus, an indirect sign. You're looking for subdural effusions or subdural epidural empyema. Finally, you might have venous or arterial infarcts. So let me show you some cases. That would be kind of a typical case, relatively young person, and the question is meningitis. This would be non-enhanced CT, and this would be CT after contrast enhancement, after contrast injection. So if you look at this one, you can't say that this is really hydrocephalus. You don't see anything much. It's a young person. You don't see a lot of subarachnoid spaces. But still, they're not enough. You should see some of them, something you should see. This is kind of like not enough. If you give contrast agent, then again the discussion starts. If it's not a very prominent meningitis, you might not see a real meningeal enhancement. So would somebody of you call this meningeal enhancement or not, or still not? So basically CT is then done and you say there is no other pathology, so it is consistent or could be meningitis, and they will proceed with the lumbar puncture. If I can, in my own situation, I like to do MRI. It's easier for me that I can exclude any other complications to see, and maybe the best sequence for meningitis would be to use FLAIR sequence. So on FLAIR sequence, all CSF spaces should be dark. You remember that. So this is CSF intraventricular, it's dark. And these are the subarachnoid spaces outside, and they're all very bright on FLAIR. So this is definitely something that is not good. So this is maybe meningitis, or this is subarachnoid hemorrhage, or it's meningeal carcinomatosis. So basically 3 major differential diagnoses for the bright CSF spaces on the FLAIR sequence. In this particular case, it was a pneumococcus meningitis. We have additional findings, which is this one, small little dot on this side, and we have maybe a small little one here. This is a diffusion-weighted sequence. It has high signal on diffusion, low on ADC, so this was a small infarct as additional finding of this meningitis. One other possibility would be that you have bright subarachnoid spaces, and then you have some effusions in the subdural spaces. This will be this case. Maybe I'm not sure if you see it really. This is this. You have some effusions, and the discussion is this still sterile, or is this maybe purulent? And then you will see this with diffusion weighted sequence. This is then T1 weighted sequence after gadolinium injection. Again, we still discuss this. This is always so difficult in meningitis. Some clinicians think if they don't see meningeal enhancement, then it's not meningitis. But in many, many cases, you will not have meningeal enhancement. This one, we can discuss, is this a dural enhancement? Maybe it is. This is just a normal T1 weighted sequence, 3D. What I like to do some additional sequences if I'm looking for meningeal enhancement, any kind of FET suppression or magnetization transfer contrast. A few years ago, there were some publication on T1 with magnetization transfer contrast and gadolinium to see meningitis. And maybe you'll see this. These are kind of small little lines exactly in this region. That's definitely too much. You wouldn't say it here. But here I get always very suspicious. If I see this, then I said this might be a meningitis. You can, of course, also use T1 with flare and gadolinium. There was an Italian group, if I correctly remember, from Massimo Gallucci group from L'Aquila, who published something, how good T1 with gadolinium and flare is for meningeal disease. Okay, so these are subdural effusions. They got already infected. That's not just a sterile. They have some high signal on this diffusion. So you see this, all the subarachnoid spaces are bright. The CSF signal in the ventricular system is okay. And you see that there is something here in subdural spaces that's very bright on diffusion. It's low on ADC, so this is already infected. This is then called subdural empyema. This poor patient has a very bad dentist, and you can almost see that it was something extractions of some teeth and some implants and whatever they did with her, but you see that infection is probably going up, and now she looks like that. So it's very crucial to have a very good dentist. So again, how to distinguish is if subdural effusions are sterile, just hygromas, or if they're empyema. I just put this here in the first row. This is a sterile, this is bright on T2, this is low on T1 after gadolinium, and it stays dark on diffusion. So this is normal fluid, put it that way. This one is subdural empyema, which is very bright on diffusion. So that's how you will distinguish that. Another possibility which could be associated as a complication, you could call it, from meningitis would be ventriculitis. This is sometimes difficult to see. When you see the ventricles and the dark signal of the CSF, and you see this, and all of a sudden you see something like this inside the ventricles, then this is very suspicious of ventriculitis. Sometimes you might see that if you have blood in the ventricular system. But in this particular patient, when he has meningitis, then this is ventricular debris, and this is called ventriculitis. Finally, hydrocephalus. I don't have to tell you much about that. It's a very widened ventricular system with signs of decompensation as an indirect sign of a CSF circulations problem in meningitis. A special form, if you want to call it that way, will be tuberculous meningitis, what we see relatively frequent or more frequent than we used to. And just to remind you what it is pathologically, you have a thick gelatinous exudate and the basal part of the brain. Then all these infections go to the small arteries and veins, and they will cause arteritis, and then small infarcts, which will be usually in the middle cerebral artery territory. We have then communicating hydrocephalus, of course, because we have CSF flow problems, and finally we have cranial nerve involvement. So let me showcase this. This was a 70-year-old lady. Again, a meningitis. This is a flare sequence. You see that all the subarachnoid spaces are very bright. Also here on the surface in the basal region. Although all the subarachnoid spaces are relatively bright, the major infection, if you want to call it, will be here in the basal cistern. So you call this meningitis, and you can make a suspicion. This, of course, could be tuberculous meningitis, so they will have to check that. This is another one, extensive tuberculous infection. This patient had something here. It's something relatively dark here in the basal cistern. It's here, then definitely this patient has hydrocephalus, sign of decompensation, and it remains dark on T2, very dark, and it has some contrast enhancement. This was tuberculous meningitis with a huge tuberculoma. And what was the key finding in this one, on what would make a suspicion of tuberculosis, was a very low signal on T2, which should be something very suspicious of tuberculous infection. It's very strongly enhancing. This is another one, a patient that we made a suspicion of tuberculosis, and we were right. You see this has a bilateral lesions in the basal ganglia. This is diffusion, and it is bright on diffusion. It was also low on ADC. If you start thinking, why would somebody have bilateral infarcts in the basal ganglia? It doesn't really fit to any territory, any particular artery, or any particular disease. So this is somehow very suspicious, especially if you have a patient from endemic area or immune-compromised patient. I had several HIV-positive patients that had tuberculous meningitis, which you see here on a T1 with gadolinium, with associated bilateral infarcts in the basal ganglia. This would be a case of tuberculosis that has almost all imaging findings that you might find in tuberculosis infection. Let's start with this one. So it has a very prominent meningeal enhancement. See this one, this is all meningeal enhancement in the basal region. So it has basal meningitis. Then it has hydrocephalus, of course, very wide ventricular system with signs of decompensation. Then it has bilateral infarcts in the basal ganglia. This signal intensity is here. And finally, small tuberculomas almost everywhere in the brain, ring-enhancing lesions. This you would call, if this would be in the lung, miliary tuberculosis. That would be kind of like miliary CNS tuberculosis. This was a child from endemic area. So to summarize a little bit meningitis, we will see some more in workshop. FLAIR is definitely the most sensitive MR technique for the detection of meningitis. You're looking for the high signal of subarachnoid spaces. Complication like hydrocephalus, infarcts, ventriculitis, sinus thrombosis, and effusions are common findings. You should look for them. You could have them without having meningeal enhancement, and the differential diagnosis would be carcinomatous meningitis, which is much more common as dural enhancement. So if something is enhancing like more dural than meningeal, then you should always consider other pathologies also. Means carcinomatous meningitis would be one of your potential differential diagnoses. We move to abscess, which is maybe a little bit more easier. Abscess starts as cerebritis. First we have necrosis, that is poorly demarcated. We have a softening of the brain. And then finally, the organism is capable to form an abscess as a reaction. We have liquefied necrosis, which is inside. We have a collagen capsule around it with a zone of gliosis. How do we see that in imaging? This would be like a perfect abscess. If everyone would be like this, it wouldn't be so difficult. So this is a liquid center, which is hyperintense on T2. This is collagenous capsule that has usually 3 layers. It's not that you see it in every case, but you might have it. And then you have a huge edema around it. That's on T2. And usually, even if abscess is small, edema is relatively prominent. And then you have T1 with gadolinium. Enhancement is smooth and nice, and it's thicker on the outer side. This would be the perfect abscess. They don't look perfect in every case. To be honest, they almost never look as perfect as that. This would be multiloculated abscess in the frontal lobe, which has, again, all characteristics of an abscess. It's just much bigger. It's liquid center, dark capsule around it, which is here on T2. This is T1 and a FLAIR, and this is then a relatively smooth enhancement. These are abscesses in the posterior fossa. They're usually associated with infections in the mastoid region, like in this one or this one. This is enhancement, relatively smooth and purulent fluid inside, and this is again T2 with a capsule. If you look carefully in those cases, you will always detect all the imaging findings. One of these new techniques that we now use, that everybody is using, this is of course diffusion. This would be a case of a pyogenic abscess with FLAIR, T1, then gadolinium, and this is diffusion, which is bright on diffusion and dark on ADC. And the reason for restricted diffusion in the brain abscess is a high viscosity fluid, which enables the water molecules to move whatever they want. So to summarize, just a normal brain abscess would be, we will have high signal intensity center and low signal intensity collagen capsule on T2 weighted sequence. We have very marked perifocal edema. We have high signal on TWI and a low ADC due to the restricted diffusion. We have ring-like enhancement, and if we do perfusion, we will have low cerebral blood volume in the capsule region. And the major problem in the everyday practice will be to differentiate abscess from a necrotic neoplasm. So I put this like this. What are the nasty questions that your clinicians will want you to answer? Because that's going to be now your job. Can I distinguish this abscess from necrotic neoplasm? Or as neurosurgeon would ask you, are you sure that this is not a metastatic disease or necrotic abscess? Can you tell me if this is bacterial or fungal abscess? Then is this tuberculosis or could this be tuberculosis? And finally, if you're dealing with HIV population, how do I know if this is toxo or lymphoma? Now we're going to try to answer these 4 nasty questions. So how do I answer the basic question? Is this abscess or is this necrotic tumor? Look at these 2. Both don't have very nice enhancement around it. So both could be abscess or metastasis. That's why we use diffusion. This is a very simplified approach, of course. In an abscess, high viscosity. This was what is yellow. It's actually kind of like pus, purulent fluid. These are normal cells, and these are the vectors, how the water molecules are moving. So we have a high viscosity content, a lot of purulent fluid, and water molecules cannot move. In a necrotic neoplasm, if it's metastasis or glioblastoma, this is a low viscosity content. It's less cellular. You see, you have a little bit cells and maybe some erythrocytes, and the vectors are much bigger. So water molecules can move in a necrotic neoplasm much more. So this is how it would look like. You have a lesion in almost the same region. One is here and one is here. This one has maybe a little bit more edema. After gadolinium, both looks pretty the same, right? So not much that you can do. Then you do diffusion and everything is clear. This is bright and dark, this is an abscess, and this is dark and bright, this is tumor. In a majority of the cases, it will work. This would be such a case, CT case, you know, the neurosurgeons were like, what is this? The patient does not really have infection signs, so it's a strange location. Okay, let's put this patient into MR. But in MR, we are confronted with the same problems. It's again lesion that it's bright on T2 and then it's enhancing, but not really nicely enhancing. And this was then diffusion. It was very bright, and we said this is definitely an abscess. We go for abscess, that cannot be anything else. And they did drainage, and it was an abscess. If you want to go even further, if you like sophisticated imaging, if you say, okay, diffusion is not enough, you might help yourself with perfusion. So what should you expect in a brain abscess with perfusion? Both are brain abscesses, both are bright on diffusion and low in ADC. This one does not have anything, no cerebral blood volume increase in a capsule region. So majority of the abscesses will be like this. Sometimes you might have a little bit of increased CBV in a collagen capsule region, like this one, like a thin line, but not really a lot of increased CBV like you would see in a necrotic neoplasm. So this would be an abscess here, bright on diffusion. This is then perfusion. This is the center, and this is a little bit of increased CBV in a capsule region. On the other hand, this is necrotic neoplasm. This looks really completely different. This is T2, this is gadolinium, this is perfusion. Now you have a lot of increased CBV in a part of the tumor that is still solid, and this is diffusion and remains dark. This is again just to see it many times. This is an abscess and this is a tumor. Abscess with bright on diffusion and no increased CBV on perfusion. Necrotic neoplasm, dark on diffusion, and then a lot of red parts, increased CBV in a solid tumor parts. Okay, you can even manage your patients or manage the therapy and see how it's working with only actually 2 sequences. If this abscess after drainage comes, of course, every week, and you have to do 10 sequences again and again, maybe then it's too much. I said I'd rather have this patient relatively often, let's say once a week, but then like 2 or 3 sequences. Just see, T1 with gadolinium, then I can see how abscess is getting smaller. And if I do diffusion, I can see what is inside. Is it still dark like this, or is something new happening, like in this particular case? The abscess was being smaller, but it has kind of like reinfection. It was getting purulent again because it was bright on diffusion. So you can use diffusion also to monitor these patients. Other nasty questions. So this one was relatively easy. We have some tools to distinguish necrotic neoplasm from bacterial abscess. This is much more difficult. It's bacterial or fungal. To put it immediately at the beginning, Usually, you are not a normal patient and walks around with a fungal abscess. As a normal immune competent person, you don't get fungal abscesses. You have to have some problems, underlying disease, some kind of immune compromised situation. But still, let's look at imaging, because sometimes you don't know anything about the patient. The most common fungal agent in bone marrow transplant patient is Aspergillus. So these are patients that you will be very alert and you will think of a fungal abscesses. This particular population, transplant patients. What I can give you from an imaging part is that these abscesses are usually dark on T2. So this one is a little bit smaller and is a nodular, but dark on T2. This one is a little bit bigger or much bigger, but it's still dark on T2. And that's not how bacterial abscess looks like. We just discussed that. Candida abscesses are even more tougher. I was recently collecting them and I found out the majority of these Candida abscesses were usually small little abscesses in the white matter or in the cortical region, so very difficult to depict, usually again in organ transplant patients or bone marrow. So fungal abscesses tend to be microabscesses much more often than the bacterial abscesses. So people said, okay, let's use diffusion to distinguish that. We did that study a few years ago and it was not helpful at all. So this one is very bright and dark, and this is Staphylococcus. This one is maybe not as bright, but still dark on ADC, and this one was Aspergillus. So then we thought, okay, let's look some more cases. Look at this one. Huge lesions here and a very thick enhancement. You would really worry if this is a tumor or abscess. This is then diffusion with ADC, very bright. So again, you would go, this is bacterial, very bright on T2. Unfortunately, this was definitely not bacteria. This was a fungal abscess, which now it's clear. You can't use diffusion to answer this question. We did some measurements. I'm sorry, I'll go back. And you see, you can always find something. If you measure something, there is always be a statistical significance of something, but it will not really help. Fungal abscesses have a tendency to have a little bit higher ADC, so less restricted diffusion. But what are you doing with all this, which are actually in the same range? So you can't really do this. I try to suspect fungal abscesses only if I know something about the patient, so that patient belongs to a group where fungal abscesses will come, and I always go back to the T2 sequence. If something is high on T2 centrally, then I go more for bacteria. If something is dark, then I dare to say, or I make a suspicion of a fungal abscess. So to summarize, that would be like key points of fungal infections. High point intensity centrally on T2. Sometimes no enhancement is common thing, unfortunately, in immune compromised patients, and something non-enhancing in bone marrow transplant patients still can be fungal infection. They tend to be hemorrhagic. They like cortical location, a lot of blood in cortex, they love this, and they have tendency to have micro abscesses. That would be something, if anything fits or all fits, then it's perfect for fungal abscesses. Again, for those who are dealing with AIDS patients, the same question that we still have, toxo or lymphoma. I on purpose picked this one as a case because it's the same location and looking the same. So what are we doing? We tried diffusion again and measured all kind of ratios. It didn't help. Now we combined a little bit diffusion with perfusion and tried to give an answer. This is toxoplasmosis, low on diffusion, low on perfusion. Some people do spectroscopy. I personally don't do that. I don't believe that spectroscopy can reliably distinguish. Either you find something like this, which you can find in many other diseases in your radiology, high choline, a little bit low NA, or you find this, a lactate lipid peak, which you can find in toxo and in lymphoma. Americans do thallium SPECT, or maybe you have institution that is doing this, and they claim very high specificity and sensitivity. So this would be toxo, which remains non-enhancing, or how would I say that, non-uptake, no uptake of thallium. I'm very bad in nuclear medicine. And this is lymphoma, which has a high uptake of this thallium SPECT, so this is very easy. What we do, if we have time on the scanner, is FDG PET, which also has a very high sensitivity and specificity, much more than MRI. This was the case of lymphoma, in an HIV patient, non-enhancing, just 2 small lesions, and this was positive PET. This was toxoplasmosis, where PET was negative. 1 huge lesion here in the basal ganglia was negative. So whatever you choose with MR, you are not really safe enough. It's not really good enough. I guess you have to kind of like additionally do some nuclear medicine stuff. Could this be tuberculosis? This is the 4th question that we have. Well, this is tuberculoma and this is tuberculoma. So when do we suspect it? This is a case that I got from Peru. Huge lesions, very bright. They look like a bacterial abscess, but it was a real tuberculous abscess. So it's kind of tough to say this is tuberculosis. This was a child. This case I had in Vienna, very strange. This was also tuberculosis. Almost everything was located in the posterior fossa. Very dark and ring-enhancing lesions here, dark on T2, hydrocephalus, and then additional small tuberculomas in the supratentorial region. We just suspected this diagnosis based on patient's name, to put it that way. This is, some people claim to be able to diagnose tuberculosis based on spectroscopy because tuberculomas should have a high, or at least you have to find it, lipid peak. So if you do something like this and see a lot of lipids inside of the lesion, it should be very suspicious of tuberculous infection. I guess we don't have maybe enough cases in Vienna to prove it from our own experience. Let's move to encephalitis, and the most important one that I want to show today is herpes simplex encephalitis. Still very high mortality rate, and it's still very important to diagnose it very early. What is herpes simplex virus actually attacking in the brain? That is maybe the start. It's attacking the old brain, as the new classification of old and new brain that Professor Valavanis is now introducing. The old brain is kind of in the center of the brain. And these all parts belong to that old brain. And this is hippocampal region, and then going to the cingulate gyrus and going to the insula. So this is it. This would be FLAIR sequence, and everything is here. And this is so-called old brain. So this would be in a subacute stage. Then, of course, you have some cystic regions of the brain that already undergo cystic degeneration, and you have a little bit of enhancement. In acute stage, you will not have enhancement. You just have high signal on FLAIR in particular regions of the brain. Okay, so this is a subacute stage again. Then you will have enhancement, which is gyriform and the periphery of the lesion. And then chronic situation, it will look like this. Can we use something new for FLAIR? If you do it with a CT, you will need 2-3 days to diagnose it. That's definitely too late. If you use conventional sequences, then people say you will need 24 to 48 hours if we're using FLAIR sequence. So it's still a little bit too late. I think that FLAIR is diffusion-weighted imaging is now relatively helpful. I have collected few cases and we saw it very early after a few hours, and this would look like this. I purposely picked this case, which is of course prominent case of herpes encephalitis, just for teaching purposes. It's not always going to be as prominent as this one, but it's bright on diffusion in the cortex. You see, it's not a white spot like an infarct. You see almost like outlining of the cortex, white line where the cortex is involved. This would be another case of herpes. Here it is in a hippocampal region. Here it is here, and here in a thalamic region. And then this is diffusion. It's subtle, but you should look at it. You know what I mean? If you miss it on a FLAIR sequence, other sequences, then you will probably detect it on a diffusion-weighted image. So the key points will be the particular regions in the brain, not every region, temporal lobe, hippocampal region, insular cortex, and cingulate gyrus. High signal will be seen on FLAIR. Enhancement will be present in a subacute stage, so not early on, don't expect that, and you will have high signal on diffusion. And your main differential will be low-grade tumor. We will discuss this in the workshop. I will bring this disease under encephalitis because now it's coming more and more, and it's coming associated with HIV patients and with multiple sclerosis. Now we have the 40th case of PML with a particular therapy of multiple sclerosis. That's the reason why I'm bringing this disease. So what is PML? PML is actually a viral disease. through GC virus, which is actually usually in the organism. I think in a French population, it was a study, 70% or 80% of people, 5 minutes, okay. Okay, so maybe we should, I will try to speed up. If we stop, the rest we will do in workshop. So it stays in a renal tuberous cells, and then it can be reactivated. It will look like this, white lesions in the brain that go deep into the cortex, and it will be non-enhancing. This is how it looks like. This is pathological slide. This is flare. So finger-like signal intensities in the brain going deep into the cortex. This would be a typical patient again. Here and here, multifocal. It is here. The subcortical U fibers are involved, which is very important, and it remains dark on T1 and non-enhancing. And this is how it looks like. I'm going to skip this one and show you this one. Now we have some therapy for PML disease, which is not a specific therapy. We give antiretroviral agents, and PML might react very prominently, which is something that you should know. This was initial MR, very prominent demyelination due to PML. Then therapy was given, and then it looks like this. So it has a very patchy but strong enhancement, almost intravascular enhancement. This is something that it's a reaction, and that it's called iris. So this is post-inflammatory reaction that you should know. It's actually good, prognostically good sign. Let's move further, so I will skip that about multiple sclerosis, and we will discuss that then in workshop. That's my diagnostic algorithm, and it looks very complicated, but it's just this slide. So on conventional sequences, before you go to all these advanced and clinics that you have to know, you look always at T2. That is very important. You look on T1 if something is hemorrhagic, or you use susceptibility weighted image. So unconventional. This you use, you know, if you want to do some advanced imaging, diffusion, perfusion, spectroscopy. And I think even more important than this is you know something about the patient. If you don't know anything, it's going to be extremely difficult. What do you look at T2? Why is this part of the algorithm? Everything which is low on T2 is here, so this is important. You have to have suspicion. Dark on T2, fungal, tuberculoma, toxo, or lymphoma. Not so many things, so go always back to T2. High on T2, bacterial abscesses, toxo unfortunately here and here, and some real tuberculous abscesses. You have it in a syllabus. Clinical information, very important. If this is an AIDS patient, then you have a long list. If this is a bone marrow transplant patient, then you can be sure it's one of the three things if it's in the brain. It's either toxo or aspergillus or lymphoma, not much. And IV drug abusers usually get some bacterial abscesses. Politically very incorrect, what I'm going to say now, but very helpful. It's to know where the patient is coming and to ask nasty questions. If you look at this, there is no way, maybe you are so clever, I'm not, to see immediately what this is. I have never seen something like that, something in the spinal cord and here. If you know that this patient is coming from United States, and I apologize again for this slide, then you might come with a diagnosis of Chagas disease, you know, something very rare. But if you don't know anything, this is something that is happening in the States and you won't see in Europe. So there is no chance that you diagnose this. If you see this, I was not sure what this is when I saw this case for the first time. And it was a patient coming from Turkey, so I was thinking of all kinds of diseases that exist. But then somebody was teaching me in one of the courses, this is very common in Switzerland. Maybe you know what this is. I learned it then. It is alveolar echinococcosis. Right? So this is, it's helpful to know where the patient is from. And if, of course, you see this cyst and the patient is coming from Turkey, this may be going to be cystic echinococcosis. Or this one, strange cystic lesions in the brain like this and then this. Doesn't look like anything that you like, and this patient was having a nice holiday in Belize or whatever, then you know that this is going to be cysticercosis. So I'm going to skip this one at the end. I'm sorry, I don't know why I put this one. So again, there are so many diseases that I love to show you, all these kind of cryptococcosis, sparganosis, and all these beautiful names. Even malaria in the brain. You can have all these diseases in the brain, and we will try to do this in workshop. So to look at list is where it's located. You decide first, are we talking about meningeal disease or brain? T2, diffusion, perfusion, CBV, and spectroscopy. Always. You have this in the syllabus. And to ask for, go and ask your clinicians, or in particular difficult cases, go and see the patient as radiologist and see if this is an HIV patient, drug abusers, traveling, and anything. You need some information to get to the real specific diagnosis. Okay, thank you, and I'm sorry if I took more time.